Hello, this is just a voiceover PowerPoint about Parkinson's disease, as well as some Parkinson's plus conditions, just to help um, with, well, primarily just for study purposes, to help us get through our exams. So hopefully this voiceover is helpful, a helpful aid in your study. So let's get started. A little bit about pathophysiology about Parkinson's disease, which is actually quite relevant given the pathophysiology itself can help you sort of predict the signs and symptoms you might expect to see, particularly in Parkinson's, where the primary problem is accumulation of alpha synuclein. So therefore, we label these conditions as alpha synucleinopathies. And the alpha synuclein essentially forms Lewy bodies that are found throughout the nervous system and primarily accumulate in the dopaminergic pathways in the brain, so the nigrostriatal and mesolimbic parts, which you can see here in the diagram I've highlighted. There don't appear to be any strong epidemiological factors involved in the pathophysiology of Parkinson's. And there are some genetics involved, but they're generally early onset, and I don't think they're particularly examinable for us at this stage. So I think in the literature it is very confusing sometimes reading about these conditions. Obviously, there's idiopathic Parkinson's disease, which I think we're all pretty familiar with, which is primary progressive neurodegeneration. There is diagnostic criteria for it, and it's very well defined. And then the terms atypical Parkinsonism and Parkinson's plus, I think, are used interchangeably, and they have, some of those classical Parkinson's-like features, so some bradykinesia, sometimes some tremor, some rigidity and postural instability and those sorts of things. But they have, a different time course often, and they may also have some other complex neurological features. And I think that, that's largely because that area of degeneration or the abnormal accumulation of proteins extends beyond the area of the substantia nigra. You can get secondary Parkinsonism, which is caused, by drugs and infections or other CNS lesions, which is always something to consider. And then, I guess there's some type of functional neurology where you can get sort of Parkinsonism features that, aren't caused by neurodegeneration or drugs or whatever. When we talk about the Parkinson's plus syndromes, we're mainly talking about progressive supranuclear palsy, corticobasal degeneration, and then multisystem atrophy and Lewy body dementia. And out of those, the Lewy body dementia and the multisystem atrophy are both alpha synucleinopathies and share some similar prodromal features to idiopathic Parkinson's disease, whereas progressive supranuclear palsy and corticobasal syndrome are a little bit different. They're caused by tau accumulation and therefore don't share the same prodromal features. So redirecting our focus back to idiopathic Parkinson's disease. So there is a diagnostic criteria. So you have to have decrementing bradykinesia. So that is, it's reduction in both the speed of the movement and also the amplitude of the movement as well should be reducing. And then plus you can have either rigidity or resting tremor, and the resting tremor is generally asymmetrical. And it should be a frequency about 4 to 6 hertz is the definition. So you only need to have one or the other of those, but you definitely have to have bradykinesia. And then there are some other sort of features or supportive features that might help you come to the diagnosis of idiopathic Parkinson's. All of the alpha synucleinopathies, 10 to 20 years before the onset of those motor symptoms, people often get olfactory loss, so loss of sense of smell, anosmia. They can get REM sleep behavioural disorder, and also constipation. There is some staging that can be used in the description of idiopathic Parkinson's. I think it's the Braque staging system. It's just the generic staging system with criteria sort of 1 to 6 stages. But really, I guess they're broken down into 1 to 2 being like the pre-symptomatic stage, 3 and 4 being the symptomatic stage, and then 5 and 6 being sort of the late stage where you get the cognitive and psychiatric manifestations of the disease, which I'll go through in a little bit more detail. But there's not that much utility in knowing specifically about the exact wording for the staging and that sort of thing. So going back to the motor features, so you can broadly classify the features as motor and non-motor. So when we talk about the motor features, we're talking about the bradykinesia, and as I said, reduction in both speed and amplitude of movements, and then you can get other things like freezing, particularly in relation to gait and that sort of thing. There's the tremor, which is generally asymmetrical, worsened distraction. You don't get head tremor in idiopathic Parkinson's, so if there's head movements involved, it's not going to be idiopathic Parkinson's in the answer. There's rigidity as well, which you can kind of elicit that sometimes with repetitive movements in the contralateral limb as in distraction. And then postural instability is a big one as well, which results in falls, which can be quite damaging. But I think the postural instability, I guess, is maybe seen a little bit later on, whereas in some of the other Parkinson's plus syndromes, postural instability is often an earlier sign, but in idiopathic Parkinson's you'll get the bradykinesia, tremor, rigidity sort of first, and then sort of progress to that postural instability, and then gait problems, ignition failure, shuffling, fascination, freezing. One of the things to keep in mind about idiopathic Parkinson's is that they should still be able to heel-toe walk. So if someone's got a wide-based gait, that's more a sign of something else, a cerebellar problem or something like that. It's generally, that heel-toe, that narrow-based gait is preserved in Parkinson's. So that's often a useful distinguishing feature in some of the exam questions. And then, you get sort of that loss of facial expression, classic sort of blunted expression. Early signs that you can see in gait actually as well is loss of arm swing, which can also be quite a useful early sign. Non-motor features, so REM sleep behavioural disorder, very common. So basically what happens there is normally people in REM sleep, they become atonic. And what happens in REM sleep behavioural disorder is two things. One is you lose the atonia, so you no longer have the atonia, and then the two is you get quite vivid dreams that are often violent in nature, and because of the loss of atonia, you get enactment of those dreams. So often people will say that they've injured themselves in sleep, or they've injured their partner during sleep, and that can be quite distressing. There's not a lot of treatment options for that. So the treatment of the motor symptoms, except the postural instability and the non-motor symptoms, is quite different for Parkinson's. But for the non-motor features specifically, when you talk about REM sleep behavioural disorder, there is a little bit of evidence for melatonin and a little bit of evidence for clonazepam, but they don't really work. And specifically the melatonin is thought to maybe restore some of the atonia, but again, it's very limited evidence. And then obviously you have the cognitive and psychiatric problems, which usually develops probably over the course of about 2 to 3 years from the onset of motor symptoms. So motor first and then cognitive later. Whereas, in Lewy body dementia, you get the cognitive first and then you get a bit of the motor symptoms sort of after that. But the main feature there is cognitive problems. Idiopathic Parkinson's, mainly motor, and then you get the dementia after that. So here's a little question. This is quite a common exam question. Bit of trivia. The answer here is pramipexole. So all of the dopamine agonists can exacerbate impulse control disorders. So if you have someone who's, a previous alcoholic, or someone who's got a gambling problem, or someone who has tendencies towards compulsive behaviors, you really should be avoiding dopamine agonists in those people. So treatment, I guess, and this is all, for those motor effects that we're seeing, the bradykinesia, and the slowness of the movement is, where the aim there to try and restore that is by increasing the endogenous dopamine level in the brain. First line generally is levodopa. So guess you can see here in this diagram that we have the blood-brain barrier here, we have levodopa here, and it generally doesn't easily cross the blood-brain barrier. So you really only sort of get 10 to 20% of the levodopa crossing the blood-brain barrier, which is why when we give levodopa, we always combine it with a DDC inhibitor. So, benserazide or something like that, to stop its peripheral breakdown before it can cross the blood-brain barrier, and that's quite important. So that's why you'll see it's always a combination drug, so Sinemet or Matapar. What we can do is we can impact this system in multiple ways. So first line being this, the DDC inhibitor plus the levodopa. You can have COMT inhibitors to further help stop the peripheral breakdown or central breakdown. Some of the COMT inhibitors work on both sides of the blood-brain barrier to help stop the levodopa from breaking down. We have MAO inhibitors to stop it from, again, being broken down by MAO, the dopamine. We can increase the dopamine availability between the presynaptic and postsynaptic neurons at this stage, and then we can help stimulate the dopamine receptors as well in the postsynaptic neuron. So quite a few different ways, but you can see that, the best and most effective is, I guess relatively obviously the levodopa. You give more, you get more across. It has the best effect, whereas the other treatments are really adjuncts. So I guess we'll talk a little bit about how we use the drugs in a moment, but just to give you an idea of what actually happens across the course of the disease, you have early Parkinson's disease, where you start to get the features, and in that phase of the disease, you actually have, quite a reasonable size range or concentration at which the levodopa is doing what you want to do, so you're getting a predictable effect, and it's resulting in good, what we call on time. So that is when the symptoms are well controlled and the movement is much better. And so during this early Parkinson's disease, you have a predictable effect of the drug, and you have a pretty reasonable therapeutic window to work with. The natural progression of Parkinson's disease is that over time that therapeutic window narrows, so it becomes narrower and narrower, and unfortunately at the same time the effect of the levodopa, or the doses of levodopa, becomes less predictable over time. So you have relatively predictable at moderate PD, but then once you get to advanced, you get unpredictable. The other thing to note is that when you go above this sort of therapeutic window, you get what's called dyskinesias. So it's essentially when you overshoot that area, you can get, troubling problems with movement. So there are medications that can be used to help with dyskinesias if that's a problem. I mean, you can reduce the if you find that you're just overshooting because the dose of levodopa is too high, you can reduce the levodopa, or you can reduce the dose and increase the frequency sometimes to target that, or you can add in a COMT inhibitor to help extend the life of the levodopa if you're finding people are turning off a little bit early, or if you've got problems with dyskinesias, then you can sometimes use amantadine, which is an NMDA antagonist that can help, I guess, get rid of this little bit above here and get us back down into this range. So all these adjunct medications are used essentially to try and balance things out and even things out, because I guess what we're trying to aim for is as few motor fluctuations as possible, but unfortunately there's no real avoiding it when after the disease progresses to sort of the advanced stage. So here we go. So basically the dopamine agonists, I guess, over on this side are helpful for overnight sometimes, and sometimes for off periods early in the morning. And they can also be helpful if someone's nil by mouth. So rotigotine, the patch, is a dopamine agonist. So you can sometimes utilize that if someone's nil by mouth. But I guess having a look at the complexity of the system that we're trying to intervene on, you can imagine that just a dopamine agonist is potentially a poor substitute for all of the medications that a person is on, particularly if they're a bit more advanced. So this is a bit of a summary, I guess, of what's going on. So I didn't mention MAO inhibitors earlier, but essentially the MAO inhibitors can sometimes be used first line if a person's young. And the benefit of that is that if you're a levodopa for a very long time, there's evidence that that can actually worsen dyskinesias later on. There's like a dose-dependent effect of it. So sometimes people try and use a levodopa-sparing agent initially if they just have, especially if they just have mild, pure motor symptoms that could potentially be sorted with a MAO inhibitor or a dopamine agonist. But generally, they're not suitable for that, because I guess the MAO inhibitor, if I just try and go back, oh no, I can't go back anyway. The MAO inhibitors in particular, you can get you can get like a what do you call it, a tyrosine crisis. So you're going to get really bad hypertension, because the MAO inhibitors, they also break down noradrenaline. So if you block the MAO inhibitor and stop it from breaking down dopamine, you can sometimes also affect the noradrenaline pathway, and that can be quite dangerous as well. So if they're young, you can sometimes use a levodopa sparing agent. Most patients will get levodopa. If you're not able to control their Parkinsonian symptoms, so their motor symptoms, then you increase the dose of levodopa. If you have motor fluctuations, so you're going up and down, you can change the dose, break up the dose, make it more frequent, or you can add a COMT inhibitor. So that's like entacapone. So, that can sometimes be in a combination medication with Madapar, so Stalevo. And what that does is just sort of extends the time that levodopa works over. And then if you have bad dyskinesias, you either reduce the dose, but if you're getting lots of freezing, then sometimes you can add on amantadine instead to try and help with the dyskinesias. But if you're getting to that point, like most of what you're going to do is unfortunately not really going to help. It's just finding a balance. You should never stop any of these medications abruptly. If you have rapid changes in the dopamine level or rapid depletion, then you can get neuroleptic malignant syndrome. So you get change in mental status, rigidity, fever, dysautonomia, very dangerous. And that's why you've also got to be quite careful when you're changing to a patch, making sure that you're calculating the dose correctly, because even that change can precipitate NMS sometimes. There are some advanced therapies, deep brain stimulation. These are the two areas that we currently do DBS in, so subthalamic nucleus and globus pallidus internus. There are some other sort of DBS targets that they're looking at, which is not examinable. This was a slide that I had included previously for a previous talk about common inpatient issues. I think the main thing to probably highlight here that could be examinable is the use of antipsychotics. So keeping in mind that hallucinations is not a super common cognitive or psychiatric manifestation of the dementia associated with idiopathic Parkinson's, and that can often be a medication side effect. And in fact, all of the medications that we use to treat Parkinson's can cause hallucinations. So just to be mindful that in fact you may choose to reduce the dose of the medication to see if that will help with the symptoms rather than adding on an antipsychotic. All of the antipsychotics have a risk of worsening motor symptoms. The only ones that sort of don't or have evidence to not worsen the symptoms is quetiapine, pimavanserin, and clozapine. The one that has the most evidence is clozapine. So in an exam setting, that would be the correct answer, followed by quetiapine is the other one that's used regularly. The second generation's better anyway. And then sometimes you can treat the dementia in the same way that you treat other forms of dementia. So a low dose SSRI or SNRI can sometimes be helpful. The postural hypertension is a real problem, and the autonomic dysfunction is really difficult to treat. There are obviously some non-pharmacological measures, so compression stockings, and that is all the way up to the hips plus an abdominal binder, really. And then, sleeping with the bed elevated to 30 degrees, high salt diet, cold cup of water in the morning, that sort of thing. Drugs that you can use include pyridostigmine, which is a cholinesterase inhibitor, has a very mild effect on the postural drops. However, it also, because it only has a mild effect on the postural drops, it also has the lowest risk of hypertension, supine hypertension. Secondly would probably be fludrocortisone, although keeping in mind you can get electrolyte changes with fludrocortisone. And then the last one is midodrine, which is an alpha-1 agonist. Midodrine, again, has the highest risk of hypertensive side effects, but again, really tricky balance, so there's not really much that can be done about that. This is another classic exam question. So which of the following drugs is most likely to precipitate hallucinations and delirium in a patient with Parkinson's disease? Amantadine, levodopa, anticholinergic medications, MAO inhibitors, dopamine agonists. So the answer in this question is the anticholinergic would be number one. And in order of potency, it would be anticholinergic, then amantadine, then the dopamine agonist, then the monoamine oxidase inhibitor, and then levodopa. Levodopa being the last one. However, like hallucinations is actually a reasonably common side effect of levodopa. So if you had a patient with idiopathic Parkinson's who was on levodopa and a couple of other things, and they had a recent increase in their dose and then started to have hallucinations, then the answer to the question in that setting might in fact just be to reduce the levodopa. But anyway, anticholinergic should be avoided if we can. There are some studies, I had included this slide again as part of a different talk, but I don't think that's relevant to us. And then I've got a bit of summary about Parkinson's plus syndromes, which I'll go through quickly because I think that it's important to just know the features that you want to use to distinguish this from idiopathic Parkinson's, and I'll just highlight the features that they normally include in, I guess, the exam question. So Lewy body dementia, again, it's an alpha-synuclein disease. So they often do have the constipation, REM sleep disorder, and then anosmia, 10 to 20 years before the onset of the dementia. You get really quite pronounced cognitive decline, and visual hallucinations are really the key feature. They definitely have quite frequent visual hallucinations. Interestingly, they're not particularly distressing. So they have insight into the fact that, it's not normal. But yeah, the classic one is they see little people. Usually the cognitive symptoms are first, and then you might have some motor Parkinsonism features, generally quite a poor response to L-DOPA, but that would be the main thing. So 1, alpha-synuclein disease prodrome. 2, pronounced cognitive decline with visual hallucinations. 3, poor response to levodopa. That's Lewy body dementia for the exam. Multi-system atrophy, you get multiple things, again, multi-system, so you can get lots of weird and wonderful things, but generally the triad that they focus on is autonomic failure, Parkinsonism, and cerebellar signs, and often the question will include urinary dysfunction because that's quite an obvious multi-system atrophy thing. And then the head and neck dystonia, again, that's multi-system atrophy. That's not going to be the other alpha-synucleinopathies. So with multi-system atrophy, the signs and symptoms are different because the pathophysiology is slightly different in that the accumulation of alpha-synuclein occurs in the oligodendrocytes and not in neurons the way it does in the other signs. So multi-system atrophy, you'll get autonomic failure, you'll obviously get the Parkinsonism, you will get urinary symptoms, sometimes head involvement. PSP. PSP is a tauopathy, so it's different. You won't get the prodrome the way that you will in those other conditions that we've just talked about. So now you reset. This is different. I try and keep PSP and corticobasal degeneration separate in my head. I think it just makes things a little bit easier. Postural instability is really pronounced, so they'll have a wide-based gait in PSP, so wide-based gait, stiff torso, and very sort of awkward walk. The axial rigidity is often quite an early feature. They'll have postural instability, and in terms of the gaze palsy, oftentimes there'll be slowed vertical saccades, and that will be the first thing that you see. It's usually the downward gaze that's the problem, and that's often a bit later in the disease, so you might not necessarily see that. They also get overfront activation of frontalis, the muscles, so they'll almost have their eyebrows permanently raised. I think that for this condition, I think one, the wide-based gait and axial rigidity is really characteristic. Obviously, the gaze change is really characteristic. And then the third thing that they often do is they mention the retropulsion test. So that is, you have someone standing up, and then you pull them backwards and then see what happens, because it's often the backwards instability that is very characteristic that you'll see go. So if they mention retropulsion test, then that's often they're trying to hint at PSP in the exam. Corticobasal syndrome is essentially just cortical dysfunction, basal ganglia dysfunction. They'll often describe it as like an alien hand type thing. So idiomotor apraxia that affects the hand is kind of what that means. So your hand won't obey you, or you want to do a particular action and but you're not able to follow through. So that's generally the typical I guess description that they'll use for corticobasal syndrome. Again, it's a degenerative tauopathy, same as PSP, so it doesn't share those prodromal symptoms that we talked about before with the alpha-synucleinopathies. I think it'd be really unlikely that they ask about this, and if they do, it'll be a matter of excluding it, because I think the questions that you get are really obvious, or obviously asking about, a Parkinson's or Parkinson's plus syndrome, and this one I think you'll just have to come up with it. If they don't mention the idiomotor apraxia and they mention like other features or whatever, then I think the only way that you'd be able to work it out is from exclusion of the other conditions that do have quite specific features that they tend to mention in the exam questions. So that was it from me. That's the end of my slide show. If you have any questions for me, please do let me know, because that was quite a rapid, I guess, summary and potentially not as much detail into the uh, medications and so on. But I feel like that, that's a reasonable start. Then you can read about medications and whatnot in your own time. So hopefully that is helpful. Thanks for your time.